Welcome back to the Runner Zone podcast, episode 54. Chris, how are you doing today?
Things are good. Things are just took on a whole new dimension of chaos in the house because my daughter's been wanting a dog for a while, so we finally caved, and we have this very cute little Pomeranian that's storming around the house, and so here we go, man. You have aren't you training a rescue dog right now?
We have two dogs. So we have a Beagle Basset Hound that is passed out on the floor next to me right now. He likes to come up into my office and just kind of lay in the sun. And then we have a Black Lab that goes to school with my wife. She's a therapy dog, so she goes to school and works with kids all day. And so my wife went and did a bunch of training on that this last summer. So we've had her for, I don't know, 6-7 months, something like that. And so we've got a small dog that thinks he's really big, and then we have a big 90-pound Black Lab.
Awesome.
So yeah, it's great though. I grew up with dogs. I like dogs. My wife likes dogs too. She grew up with dogs, so it's all good. Who takes care of the Pomeranian? Who's in charge? Who's getting the water and taking that to go to the bathroom and all that?
In theory, my daughter, though she's been good the first this morning and yesterday, but we'll see what happens after 2 weeks. You know, this thing just basically sits on my lap. So I'm sitting here working on my computer. I don't have the dog on my lap right now just because we're recording. But yeah, I was joking on the Runner Zone this morning saying, who was it? Dr. Evil and Austin Powers, who has like the cat that he carries around. That's going to be me, but with a dog. So, yeah, but it's fun, man.
I do think that there's a lot to learn from dogs. Like, dogs are such great animals. And they remind you to like stop taking things so seriously sometimes. At least that's what I think our dogs do with us. So like our new dog, our lab that's 2 years old, she likes to go on walks because she needs, get some energy out. Especially if she's not going to school for the day, or to work for the day. And so she likes to go on walks around the neighborhood, but she takes her freaking time. Like, she wants to sniff stuff and she wants to walk around and get distracted by sounds and all this stuff. And like, me, I'm like, I gotta let's go, let's get this over with. And I think that the dogs can be a good reminder to just like chill out. Whatever you think is important is probably not important at all.
Yeah. Ain't that the truth, man?
No, it's all good. I figured we'd talk about some stuff that you and I put out recently, and then we'll get into the episode today on the hip. Do you want to touch on your last month's newsletter?
Yeah, well, that was a fun one to write. I mean, I was talking about my father who, unfortunately is dealing with advanced Alzheimer's, but he was just such a character. And, there are some very defining moments in my life that he was largely responsible for. So, in just what I talked about in that newsletter is, I started off at University of Delaware for undergrad, and I just had an incredible year, one of the most memorable years of my life. I was playing tennis. I was doing well academically. We had great chemistry and camaraderie on the tennis team. And, for whatever reason, my brother convinced me that I should transfer to Boston College to study finance. Can you imagine me in finance, man? So I made the move up there.
You should be on the New York Stock Exchange.
Yeah, maybe. So I transferred there in the fall of my sophomore year, and it was a train wreck from the outset. I was playing tennis. The tennis coach didn't get me on campus housing. Boston College, great school academically, terrible school to transfer into. So long story short, over winter break, I started conjuring up this idea that I was not going to go back to Boston College, that I was going to just take that spring semester off. And the gist of the newsletter was when my dad got word after speaking with my mom that I was planning to stay at home. And he was just basically like, F that, you're getting your ass on that plane and you're going back to school. And I did. And 2 weeks into that spring semester, I transferred back to University of Delaware. I basically bailed on Boston College and returned to University of Delaware. And unbeknownst to me, I didn't realize how strong of a physical therapy program Delaware had. So 2 weeks after returning to campus, I went to McKinley Lab, which is right in the heart of campus, and knocked on Lynn Snyder Mackler's door, Dr. Lynn Snyder Mackler, and the rest is history. I mean, that's when the physical therapy journey began. And the reason I was telling that story is because I was making the point that sometimes people are going to call you on your shit, and it's a really tough pill to swallow. But, when someone does that genuinely cares about you, that they're doing that for a reason, and I look back and think my life could have been very different. We probably wouldn't be sitting here having this podcast, and a lot of other good would have never come to fruition. So that was fun to write. And, my dad was just an absolute character. So I appreciate you reading it and dropping me a nice email.
Yeah, it's always interesting to do that. I think everybody can do that with something in their life where they look back and it's a conversation or an event. And sometimes it's a big traumatic event, but other times it's stuff like that where it's a decision or an interaction, or you connect with a professor or a person. And when you look back, you can kind of trace wherever you end up back to that moment that probably at the time doesn't feel like much of a moment. I think that happens with lots of people. So yeah, it was good.
Cool.
Yeah. And then I wanted to touch on, so I put a new blog out on sacral stress fractures. Do you see a lot of sacral stress fractures?
I see them. I won't say that I see a lot of them, but I thought that was just jam-packed with information. I watched that a few times, and for anyone who who's not subscribed to your YouTube, go subscribe to Nathan's newsletter, because it's a crash course. You almost don't need to take a Con Ed course on bone stress injuries if someone just plays along and follows your content, because you deliver it in such a concise and just efficient manner too. But yeah, sacral bone stress injuries. Anytime someone complains of unilateral low back pain, man, and they're a runner and they've done something to spike their training, or they have something in their past medical history, it's like your antenna have to go up. Talk about sacral BSIs briefly.
It's and it's funny. I had lunch with an old patient of mine, and I had treated her for a stress fracture previously. And we were having lunch. I was doing kind of a user interview with her, some of the things that we talk about in our mastermind, just talking about some stuff and getting her feedback on things. And she had been having she had seen me actually like a week or two earlier for some back pain. And she listens to this podcast. So I'm sure she's laughing right now. And I had to text her ahead and say, hey, I'm going to put out this blog post, and it's going to basically say most of the time unilateral back pain is a stress fracture. In my opinion, that's not what I think you're dealing with. Don't, you're going to read all this stuff and think you have one. I don't think you fit that classification. Doesn't seem like she does. But yeah, I see it a lot in college kids. I see it a lot more in females than males, but I've seen lots of males with them too. And I think that there's something that we miss a lot for a lot of different reasons. And so I don't know, my kind of approach to any of those articles or videos, when we are trying to dive into something specific, is that people can just get a good lay of the land of what the research and other things say, and then that can hopefully help them. Because I think that's one of the nice things about YouTube and newsletters and things like that, is they are free. And so hopefully they will help people navigate some challenging situations. Because, you and I both know with the patients that we treat, people don't always get the great advice, or people don't always get a really good comprehensive look at a topic or an injury or a thing that they're struggling with. And it doesn't change the fact that the rehab of those specific injuries is challenging. But I think that if people can be informed when they go to make decisions in the rehab process, or when they get back to training, diagnosing, all those kind of things, I think that those are the things that I want to try to put effort into, is making that stuff a little bit better for people. So yeah, I'm glad that you liked it. Hopefully other people liked it. And then you and I are going to be teaching in Spokane in a few weeks.
Yeah, which is exciting. It's just fun to be back in person, because we're clinicians. I mean, yeah, we work tirelessly to stay on top of the literature, but we're into application. Okay. You're in the clinic with someone, they come in with unilateral low back pain. What's your evaluation process? What questions are you going to ask them? What are you going to leave them with that day? Or are you going to refer them out? And I think that there's a lot of stuff that happens very fast in a clinic, and that's assuming someone's paying attention who's seeking your services. So, yeah, we have made more mistakes than you can shake a stick at. Talking about sacral stress fractures, we would have probably, back in the day, done some muscle energy technique or just treated it as SI joint pain or dysfunction. But so yeah, that'll be a fun course, and hopefully some folks in the Northwest were able to join us. We have a good turnout thus far.
Yeah, and just like the articles, the research articles, we talk about it. We'll talk about it in this episode. You can find Chris's newsletter and those blogs and videos and course information. All that's in the show notes. So be sure to check that if you're interested. So
should we start talking about the hip?
Yeah, we've talked about hips before. So we actually had Lindsay Plass on episode 39, and she is just one of the best in the world at dealing with FAI, labral tears of the hip, understanding of hip pain and all those things. And we've talked in the past, even going back to when we first started the podcast, a little bit about some of the misconceptions out there on tightness and flexibility and muscle function and those kind of things. And kind of the idea today is to try to cover, our current approach to treating the hip, the stuff that people have a hard time with, maybe some things that people put effort into that's not helpful, and how that impacts rehab, strength training, and coaching. So if you looked at kind of your approach to managing the hip, how has that changed over the years?
Yeah, great question. So as I mentioned not too long ago, I got my start at University of Delaware, and at UD, there is a huge emphasis on rehab following ACL reconstruction between Dr. Axe, Dr. Snyder-Mackler, Tom Buchanan. That was just such a focal point. So, we used to always joke when we were going through training, it's like, when in doubt, stim the quads and strengthen the quads, and that'll solve all the world's problems. And I bring that up because there is a juxtaposition. Like when I got to New York at the Nicholas Institute of Sports Medicine, they were doing a lot of research as well on the ACL. But one of the first things that I learned when I was there is just the importance of hip muscle function and proximal thigh muscle function. And Dr. Nicholas Sr., who used to go by Big Nick. And when Big Nick was storming the halls, you wanted to basically know where he was, because he would pull you aside at random points when you were treating patients, have you draw the brachial plexus, start posing all these questions. So when he was on the floor, everyone would be scurrying. But anyways, he published a paper in 1976, AJSM, the same year that Priest and Nagel published their paper, Tennis Shoulder. And the study was entitled "A Study of Thigh Muscle Weakness in Different Pathological States of the Lower Extremity." So he was just such a huge proponent of strengthening the hip, seated hip flexion, side-lying hip abduction, adductor strengthening. And I started to really appreciate the role of what impact that can have on just lower extremity function in particular. Someone came in with patellofemoral pain, starts strengthening their hip. What do you know? They start doing really well. And there's been subsequent studies published. But so when I was at NISMAT too, I also was there right around the time where Brian Kelly came on the map. And Dr. Kelly he's one of the OGs in terms of hip arthroscopy. So he would come and present to us usually once, maybe twice a year. And it was fascinating because he was focused on a lot of hip arthroscopy and labral procedures. And I vividly remember him saying, like, we don't know if this is the right thing to do, all these procedures, and you sort of appreciated his honesty. Now, he was saying that behind closed doors, right?
Yeah. Said by no surgeon ever in the general public. So I had just a really unique lens into this. And
one of my first major tissue injuries was a rectus strain, which is an injury from kicking a wet soccer ball that I've talked about, involving the myotendinous junction. And that was my first experience of like what happens when you incompletely rehab a muscle strain, which I did. And I tried to get back prematurely. So yeah, I've had a lot of pretty unique experiences and got exposed to a lot early in my career. And now with runners, it's, things have just expanded that much more in terms of bone stress injuries and some of the other common things we see, such as proximal hamstring tendinopathy, gluteal tendinopathy, femoral shaft, femoral neck bone stress injuries, as we were just talking about, sacral bone stress injuries, apophysites. Is that a plural? So
yeah, I think that is.
Yeah. Yeah. How about for you?
Yes. So, I remember, I don't know that I learned anything about labral repairs, hip labral repairs in PT school, but it seemed like when I came out, they had become much more popular. There was one surgeon in town that had just came through and moved in and said, "Hey, I'm the labral repair person." And so at the time, the clinic that I was in was a sports clinic. And so we saw everything, almost all sports, aside from, some patients in the middle of the day that were maybe more Medicare, things like that. And I just didn't know anything about it. And so we had, kind of like you were like, surgeons would come in and they would talk about, these are the approaches that I take. And this is why the protocol says don't stretch your hip flexors early. And this is why we do X, Y, and Z. And then trying to apply either the specifics of the sport that someone plays with those repairs, or just with injuries in general, like you mentioned, because there's a lot of stuff that can happen there. You can get bone stress injuries, tendinopathy, you can get avulsion fractures, you can get lots of different things, and they all get treated a little bit differently. But I remember early on, we had Vern Gambetta, who's a track coach, come in and do a weekend in service with the staff at my first job. And my boss and him had gotten to know each other at some point over the years. And so Vern came out and talked a couple times when I was at my first job. And I remember him saying, one of the questions that you should ask is, what shapes does this person have to make when they do whatever it is that they're going to do? And the way that he described that, it just stuck with me. So like hockey players, ballerinas, offensive linemen, distance runners, like whoever it is, what are the specific demands of what they have to do? What are the positions they have to get into? What are the forces that they're dealing with? And, because the hip is such a mobile joint, has such a broad range of positions and things that it has to be able to do, especially I think when you look at court and field sports, there's just so much going on that I think you want to consider when you're looking at rehab, when you're looking at strength training. And then with distance runners, it becomes a little bit more compact just because the demands aren't quite so broad. And so I think that I learned really quickly, like there's a big difference between what the hip has to do with the soccer players that we get a lot of versus the distance runner that's trying to get back to running half marathons, largely in a straight line. And then, just trying to apply that to other things, other joints, other muscles, all those kind of things. But it's definitely changed a lot over the years. And then you get all this information now, like you kind of alluded to, where you're like, well, is hip arthroscopy that impactful? How good is it compared to conservative care with a lot of these injuries? Neither one is 100%. So what are the things that we're looking for to make sure that we're helping, people with that decision-making process? So it's definitely changed a lot over the years.
Yeah. I mean, talking about hip arthroscopy too. I mean, I think of all the patients and people who I've interacted with over my career, and I'll say this, and obviously the verdict's still out on the best way to approach these, but there is a hockey player who is in the Rangers organization and a soccer player that I can think of where I'm like, that was the right decision to go in and do a labral repair on that person. And they had a good outcome. They got back to their prior level of function with sport at a very high level. But I'll also say I have seen, I would say 80% of the people that have consulted me with some sort of hip arthroscopy procedure to address labral pathology FAI, I thought it was totally unnecessary. And these people would go back in for failed procedures, so, and I don't see a lot of these now relative to when I was in New York, just because I'm working with more runners and triathletes. And, does FAI syndrome hit these people? Yes, but not to the frequency that it does with other demographics or sports. What's been your experience?
Yeah, I would agree with you. I think for those sports that require supraphysiological ranges of motion, gymnasts, again, hockey goalies, pitchers sometimes, if there's a sport that requires a large range of motion at the hip joint, I do think that those tend to be when maybe that surgical procedure is going to be a little bit more necessary. I know Lindsay has alluded to that before too. And I'll trust her opinion more than mine. But yeah, with distance runners, I just don't see that often. And I think that it's the same thing with runners that are dealing with low back pain, like runners that are dealing with FAI, or they're dealing with back pain and it's not a bone stress injury. I think a lot of the times the pain or the cause of it is not running. It's just that running is painful. And, I can think of so many patients that have had symptomatic FAI that the thing that was the most helpful is don't sit in low chairs, stop stretching your hip, stop getting into positions that are, lots of hip flexion, lots of hip internal external rotation, lots of extension. So these bigger motions, if we just get out of that and we give you some kind of, even just a basic strengthening plan, they do great with no other modifications. Now, it doesn't happen all the time, but I think that that's something that it can become really easy to say, this is what the image says. And so this has to be the thing that we do. We've seen that with the Warwick Agreement that's in the show notes. So that was a paper that was published that looked at this, that said we really need to term this as symptomatic FAI versus just FAI, because you have to have symptoms for it to be a problem. So in their definition, this big group came together and they basically said, in order to be diagnosed with this, you have to have pain, and then you have to have a relevant clinical exam. And normally that is, some special tests that we can do at the hip. Those are painful or those are positive. And then you have to have correlating imaging findings. So the imaging has to match it. And there's just been so many studies that have found like this whole group of people, yes, they have a labral tear. Yes, they have FAI, but it's not painful. And so we don't need to just go after them and say, oh, we got to repair that right now. And again, if we kind of zoom out even beyond the hip, we see that in most of the joints and muscles of the body, where you can have tears and all these other kind of things, and it doesn't necessarily correlate with pain. And that's one of the things that I think I see with runners, where they'll get into that system and down that road towards surgery. And I just don't see that. I think it's a rarity that needs to be the outcome, unless they're just decided on it. And sometimes that'll happen too, where they're like, I need to have the surgery. I feel like that's going to help me. And, I think that in those cases, maybe it is the right choice.
Yeah, there are a couple great papers from that Christian Thorberg and Mike Raymond have published. A couple other people. One was International Journal of Sports Physical Therapy. The other one was JOSPT. And those are we'll include those in the show notes. Those are just seminal papers that anyone who's forward-facing as a clinician really needs to read, just because there's countless pearls. But I agree with you. It's like, when I see people with symptomatic FAI, I mean, their general presentation is they have sensitivity when you take them into hip flexion. Sometimes they'll get pushback with hip internal rotation. When you have them just go into an air squat or have them go through a full depth squat as part of the evaluation, they get pushed back as their thighs start to approach parallel, if not before. And to your point, it's like with running, you're never in that position, Yeah. So if someone is diagnosed with FAI as a runner, I'm thinking that doesn't make sense to me, Now, the runners that I have consulted, I think back to the last person, they weren't having much pushback with running, as you just mentioned, but they said that they were sitting in a deep sofa with their knees towards their chest, like kicked off to one side. And they said that's just how they studied when they were winding down the evening and they were spending time with their family. And I'm like, okay, well, let's just get you out of that damn position. And what do you know? Over the course of a few weeks, things started to improve. But with running, you may get to 60 degrees of hip flexion. Obviously, if you're running up a steep hill, that's a different beast. But most of the time with just walking, you're around 40, 45 max. With stair ascent, maybe you're going up to 65. But it's really important to ask these questions when you're working with someone, because what you're going to find out is, like you said, it's not running that is sensitizing this.
Yeah, I had a patient years ago that she was diagnosed with symptomatic FAI. And, as we're going through this objective, she said, it hurts when I'm at work a little bit, it hurts when I'm sitting, and then it hurts when I'm running. And she would sit kind of like what sounded like your patient was. She would sit on the chair with her feet tucked underneath her, basically where the hip was in a Scour's position, which is hip flexion and internal rotation. Super, super painful for a lot of people with this. And yeah, with her, it was, don't sit like that. And symptoms tended to resolve over time, which, it's always a lot of questions and a lot of, analysis before we can really figure out, does the image matter? Is this really a running thing, or is this something else? Is it both? So, when you're kind of viewing how the hip has to function with distance running, what's your current thoughts on kind of what it needs to be able to do, what it has to do, if we just stick with flat ground running?
Yeah. So as we've echoed time and time again, the range of motion requirements for running are minimal, right? You don't need crazy hip flexion. You don't need crazy ER, IR. And this may ruffle some feathers, but you also don't need a lot of extension. And we also have to appreciate that, looking at Anthony Shake's work and other people, that it's not pure hip extension. It's a coordinated movement between the lumbar spine, the pelvis, and the femur. So, and hip extension is not different between walking, running, and sprinting. It's just occurring later in the gait cycle. So when I'm evaluating a runner, if we stick with that theme, I really want to make sure that they have adequate strength, capacity, and neuromuscular control, particularly during stance. And all the stuff that I put out in the way of drills, I hope that theme just, shines through and through, because I hammer people with neuromuscular control drills. Any good program that you and I put together, it's a combination of strength work, it's single leg balance, maybe some isolation, open chain exercises, but neuromuscular control in relatively conservative and mid-range positions.
Mm-hmm. Yeah. And, to touch on that, I think that conservative positions is one of the things that runners, if they are doing a lot of hip strengthening, tend to shy away from, because it's really easy for a runner to, at the track, in their home, at the gym, run through like Myrtle drills, which is a program that most of the high school teams that I talk with will do. And it's not that that's bad, but it's a bunch of stuff in quadruped where you're on your hands and your knees, and you're going through donkey kicks and fire hydrants and all these drills that put your hip in a really big range of motion that will make you feel tired and aren't inherently bad. But I've had a lot of people that it just bothers them, and I think a lot of that goes back to their anatomy. You had talked about Anthony Shake's work. He's looked at hip extension and how the range of motion that you have in hip extension is probably relative to your femur's length. So I have, if you're watching this on YouTube, like if you have a femur that's longer or shorter, you're going to move differently. Just like if you have a femur that is rotated in, so you're more anteverted or retroverted, so you're going to have more internal external rotation, and those levers, the bones of your body, they're going to have to impact how you move. Not better or worse, just different. So I wrote a blog years ago on two of my clients that would run together at the same pace. One was probably 5'10", and the other one was probably 5'2" or 5'3". And the runner that was shorter had a much higher cadence, had less hip extension, and the runner that was taller had a much lower cadence and more hip extension. And I think a lot of that's just due to the length of your bones. I think it's the same thing. If you watch a runner from behind and you see their feet turn out like egg beaters, they have a heel whip. I think a lot of that's determined by what the shape of your bones are like. And so you have these requirements that you need to be able to do for running, which you had mentioned the study by Mann and colleagues that looked at that. And then you have all this variability where people are going to move in all these different ways, probably based off of their genetics and their individual bony structures and maybe their training history. Cause we do see that runners tend to move differently if they've been running for longer, if they're older in age. And it's never, just so rarely are we like, you need more motion. You need to stretch out something that's tight. I never run into that in with patients or clients.
Yeah, I don't either. I never think, oh, this is an inflexibility issue. The one thing that I am always surprised about is I put a lot of high knee marching drills. With folks who have symptomatic FAI, very rarely does that even sensitize them. It's like just bring their thigh up to roughly 90 degrees, maybe even a little bit past. I would think that may aggravate some people, but I can't think of anyone who is presented with symptomatic FAI where that's created pushback, which is great. And if it does, you just back off the height of that. So now I think
it's the same thing with same thing with most exercises. Like if someone has pain at the bottom of a squat, don't squat so deep. If someone has pain with deadlifting from the floor, start with an RDL or a trap bar deadlift or something where the load is elevated. I think so much of that condition is just modifying. It's not to say don't do anything, but just find the range of motion it feels okay with. And then if it's important for you to expand that, either because you need to do a functional task or there's a lift or an exercise you enjoy doing, or maybe you're going back to something like really steep incline running, like you're, running through mountains and stuff, just over time, just ease into that.
Yeah, I mean, with squats, I don't prioritize a lot of full depth squats with runners, because they suck at them, unless they have some more elaborate lifting background. But I will do a lot of partials, and I'll load people up pretty heavy. And I also will incorporate some rear foot elevated split squats. But again, I'm not hell bent on the depth, I think a lot of people can adopt this purist mentality where they're like, oh, we have to, go ass to grass. And I find with running, that's just generally unnecessary.
Yeah. Unless you need to do it for your sport, then it doesn't make much sense to me to include it. What does your hip assessment look like? So when someone comes in and they say my hip hurts, what are you looking at during an objective examination? What tests and assessments are you looking at? And then we can talk about the stuff that maybe we don't put a lot of stock into.
Yeah. I mean, this is like a course right now. So I think the first thing is I don't know if this is just my nature, having lived in New York City. I'm thinking a taxi cab is going to jump the curb and hit me, or something else bizarre that happened in New York City. But I just observe people. And one of the common patterns that I see is that if someone comes in with a unilateral lower extremity complaint, say if it's at the hip, what you often see is they'll shift and they're essentially unloading that extremity. And you may notice this briefly. A lot of the times these people are living in that position, and then when they go to sit, maybe they'll cross that leg over the other. So I just want to see, how is this person dealing with load? Because I'm going to just stand up for a second. I know you can't see my feet, but if someone's always shifting like this, I still have my pajamas on. Isn't that terrible? But if they're always shifting over that side, you're trying to say, okay, well, is this just a habit, or is this person playing defense? Are they guarding? Are they trying to protect that side? And again, you'll see this throughout the session. So, obviously I'll take them through just a simple walking assessment, but the crux of the assessment is going to be, okay, what are the physical performance tests? And then what are we seeing when we have that person on the table, or on the plinth doing a clinical examination? So if we start with just basically having that person lying supine, I want to make sure that their heels are completely supported. And I'm just making a note. How far do their legs fall out? Are their feet, is the lateral border of their foot almost in contact with the plinth, which may indicate that there's more of a pattern of anterior capsular laxity? Is there a marked asymmetry in that side to side? From there, I may just log roll the person inward and outward and seeing if there's any click, clunk that may be suggestive of intra-articular pathology involving the labrum. From there, I want to make sure that there's nothing else that's masquerading as hip pain. So I may take that person into a passive straight leg raise. If they're up 70 to 90 degrees, I'm like, okay, well, this is probably unlikely emanating from the lumbar spine. I'm going to take them through hip range of motion. And I think for anyone who's a new grad, you really need to make sure that you're getting the end feels, because the hip is not as delicate as people think, right? So getting them into hip flexion, ER, IR, and just seeing what their response is. Are they tolerant of that? If you take them in ER, wind them up a little bit and let it spring back, because that may sensitize someone if they have a proximal femur bone stress injury. Making sure that you're taking them into hip IR. That's going to stress the labrum. People with hip osteoarthritis often will have a marked loss of hip internal rotation. And people with, again, femoral neck bone stress injuries may not love that. You could take them into a thigh thrust maneuver, which is a pain provocation test for someone with, if you're suspecting SI joint pathology. I'm going to take them through manual muscle testing. I may take them through an active straight leg raise. You and I have both seen people who have a femoral neck bone stress injury not tolerate that. And that's not a rectus issue. That's probably bony in nature. I'll take them through, a Faber as well as a Fader assessment, a hip scour test. I'm definitely not doing Ober test. I'm not doing a Thomas test. And then I would sort of take them through some of the physical performance tests or functional assessments. But let's keep that separate for now.
Yeah.
I'm just I want to make sure, is this a hip problem? And then from there, is this an intra-articular or an extra-articular problem? Making sure that we've ruled out anything from the lumbar spine, anything from the sacrum, and then from there start asking some more questions. I'm trying to disprove my working hypothesis. I know I covered a lot there. What else did I miss, or would you add?
No, I think that was good. If we kind of have that as one section and then we talk about some of the physical performance tests, I think that you're trying to figure out if you're the right person to deal with their current situation. And what to do, because
100%.
There's been lots of hip exams that I've gone through where either, I think sometimes when people hear me talk, they think that every time someone comes in, I just tell them I think they have a stress fracture. And what I'm looking for at the hip is, am I confident that this is not either something sinister or something that requires them to be non-weight bearing and honestly schedule with a physician. So, if someone comes in and we go through all those things and they're very limited and they're very painful, the examination is kind of over. Let's say I think that it's a femoral neck stress fracture, or, I've had people have stress fractures in their femoral head, have intertrochanteric stress fractures. Like, it can hit all of those, but I can't tell that in the clinic. And I definitely can't speak to confidence that someone doesn't have that if that's what they're presenting like. And so in those situations, it's my job to say the next step in this is to probably be looked at by a sports medicine physician and get some imaging. And then, I have a pretty good radar for these. I feel like at this point in time, I'm not perfect. But there's lots of times where I can't do anything until we know that this isn't a stress fracture. And if it comes back that it's a labral tear that's kind of maybe mimicking that, maybe mimicking a stress fracture, or it's something else, then that's okay. And we'll be able to progress forward at that point. But that's what I'm kind of looking for, is to get a sense for maybe how they're set up anatomically, and just try to make sense that we should be okay to move forward with anything at that point in time, instead of just saying, we need to be on crutches until you can get in with, let me set you up with the sports medicine doc, and we can figure out what the next best step is.
Yeah, and I mean, the one other test that I forgot to mention that you, as far as I know, developed or invented, was just basically having that person do maybe like a 20 to 30 degree straight leg raise, and then manually resist an adduction, abduction. And sometimes I'll just grab that person when they're lying supine, just give them like an axial load into their hip and see if that's provocative. But, I think that the one thing that clinicians, and I know I was guilty of this when I was younger, is we're in the business of trying to help people, to ameliorate their pain, to address their function. And oftentimes we get overzealous and we are doing things we're essentially playing with pain processing. And I think that's where, if I could go back in time, like you said, you're trying to say, is this person a candidate for physical therapy, or do we need to refer them out? Because less is more. Stop trying to take away people's pain instantaneously and just say, what are we dealing with? And also make sure that you're not missing anything sinister, because if someone has a history of cancer, say if they're like, a 55, 60-year-old male, we can't forget that, if someone has prostate cancer, maybe that refers pain to the hip. So there's just so many sources of nociception, so many different tissues and things that could be tying into this. And a lot of times there could be multiple entities, not just like you have a labral tear and that's it. So.
Yeah. I mean, if anybody's ever read an MRI report of someone with hip pain, so many of them have multiple things. So like, you can have a femoral neck bone stress injury and a labral tear and hip flexor tendinopathy and, whatever else, a muscle tear in your glute. Like, you can have all of that, but the bone stress injury takes precedent over the other tissues. And there's other things like that in the body. So I think you want to be conservative, and you want to have a good management strategy for this stuff. And you don't want to just focus on resolving people's pain. I think that's a very seductive thing for us as rehab providers to go after, right? Like, if you've ever had a patient where you do something and their pain like goes away, which a lot of people have, like, that's a pretty cool experience. That can be pretty enticing to go after. And, I think as I've been a PT for longer, like, pain is normally the reason that people come into the clinic. But it's not, my job is not to get you to 0 out of 10. I don't want that to be my focus. My focus is to make sure I'm the right person to handle your situation. And then we can go from there, because I've seen people like that where they have a bone stress injury and they get some manual work done, or they do something else and they feel a little better for a few days. But really they need it doesn't solve the fact that they have an injury that's going to need time off on crutches or needs a surgical consult. And I want to make sure we get to that decision as quick as possible, so we're not wasting people's time and money. And, we're getting them back to the things that they enjoy as quickly as possible. Even if that means, you're not coming in and I'm trying to make you walk out, just flabbergasted that your pain's gone.
Yeah, like you said, very seductive, and but yeah, definitely it becomes a slippery slope. So when we talk about physical performance tests to really stress the hip and challenge it, what are the things that you often are doing?
Yeah, and you've put out a resource on this. So I'm going to look at a lateral step down. I'm going to look at a side plank. If a side plank with 2 legs is easy, then we'll go to 1 leg. We can progress all that out. We can look at a bridge with straight leg raise. If they're feeling good, you can look at a split squat. You can look at a goblet squat. Once they're kind of off the table, or once we've kind of moved on past the range of motion, flexibility, special tests portion of the evaluation, I'm just trying to put more stress on the hip and see what their response is like, to figure out if there's something that we should work on, or if there's something that's concerning that we need to address. And then just backtrack from there. And that leads into running too. So eventually it's running, and maybe it's running uphill, and maybe it's running at a faster pace, or modifying some things in how you're running. But I think it should just be the stair-step process where you're stressing the hip at different angles, in different ways, in different positions, because the hip is so dynamic. And then that leads right into treatment. So if someone does seem to be a candidate for conservative care, we're confident that this isn't something that needs imaging or a referral to another provider. That's kind of how I structure someone's rehab plan. So, the hip has to go forward and back. It has to go side to side, and it has to rotate in and out. My thought is to have something that is working on those 3 motions, as well as, say, a couple big movements like a squat or a deadlift. And then we just progress that over time. That's what a lot of the rehab plans end up looking like to me. So, again, something where you're looking at like resisted marching for hip flexion. You're looking at a side plank for hip abduction. You're looking at a Copenhagen plank for hip adduction. You're, all these different things, but I'm trying to put into place a plan that really targets the whole hip and all the ways that it has to work. And then some bigger movements like squatting and deadlifting, whether that's a patient or whether it's a client and we're looking for performance, especially if they've had maybe a history of a labral repair or injuries in the tissues around the hip or something like that. That's kind of how I frame structuring a resistance plan too.
Yeah, that's great.
That we see. What's some of your top hip exercises you tend to program?
Yeah, great question. And I'll probably glance over a couple by accident, but for anyone who has worked with me, who has attended a course, who has followed any of the content I put online, I love heavy farmer marches. You can do these with kettlebells, barbell plates. You can do it with an open face trap bar. But I think that when it comes to that hip and the loads that are going on at the level of the femoral neck, when you're in single leg stance under heavy load, that's great. And you're also challenging the lateral hip musculature as well as the obliques and the hip flexors. So I absolutely love that drill. And I find that that's one of the biggest gaps when I audit someone's programming is they're not doing carries. And I got turned on to those because of Dan John, but I took sort of some of the stuff he was talking about and turned it into a march for runners. I love heavy band resisted toe taps using the Sirius steel band, the 13-inch cloth one that you turned me on to. I love barbell lateral toe taps. I love long lever bridges, deadlifts. I'll get into step ups, not getting too carried away with the height, because I feel like a lot of times people cheat those and they use momentum and then they just basically hinge their trunk forward. And at that point, it's like, well, you should just do a rear foot elevated split squat. And I love hip airplanes just as sort of a novel way to get some movement where it's pelvis on femur. I'll say that I used to really underemphasize adductor loading, starting with short adductor planks, moving to what people think of as Copenhagen planks. I like side planks with hip abduction as an assessment. I don't use them a ton in terms of my programming. Sometimes I will if I know people love yoga, Pilates, stuff like that. And I think something that also challenges like skater hops, that really just challenges frontal plane movement. So pretty much every exercise that we give. How about you?
I think you took them all. The only things that I would add is I'll do some resisted. Yeah, it's all right. I'll do some resisted marching with a band around their feet, making sure they can stay vertical. They don't lean back or they kind of cheat hip flexion. I like to do a lot of rotational med ball throws, especially that's more with like younger runners, high school and college kids. But yeah, those are, I mean, that's what most of my programming looks like. And you know, all of those kind of split it up into twice a week is normally what I'll do. Try to parse them out so they don't conflict with each other, and more load, more speed, more weight over time. So that's all I'm really looking for. Whether it's patient or client, you know, if you had someone that, you know, responded like they like some more focal loading, you can do isometrics and things like that. I just don't do a ton of that. But not just because that tends to not be what people are needing at that point when they see me. But yeah, tons of good options, you know, load the hip, load it in all the different ways that it moves, and just progress it over time. And don't get stuck on the same drills. That's an error that a lot of people run into, where they get their rehab plan, or they download something off the internet and they just stick with the same stuff forever. There needs to be a progression to it. So, well, cool. I hope everybody.
Yeah, and I think that's
episode.
Where the magic is.
Yeah.
And just to sort of follow up on what you said, I mean, the exercise it's nothing mystical, magical. I mean, the art is in knowing which variation you give at what point in time, and how you titrate that dosage, and get the person to understand why the hell they're doing this exercise and why it's important for the health of their hip. So, and then my goal is always to try and build proximal thigh strength.
Yeah, and I'm going to have a newsletter out in the next few days, and it'll talk about this. Like, and then it always has to be in your program. Like, you know, there's not going to be a magic drill that's going to fix everything and it'll go away. I think that you want a good relationship with resistance training or some kind of movement, and that you need to keep that in your program. Not 12 months out of the year, but a good chunk of your year. Otherwise, you'll lose a lot of the things that you gain from it. So it needs to be progressive, and it needs to be consistent over time.
And the one point that, and I know you have to hop here, but the one point that I love that Rich Blagrove and Glenn Howitson made in their 2018 paper talking about strengthening for distance runners is, don't hesitate to try and, like, everyone's like, oh, you know, we don't want to put mass on, la, la, la. It's fine if people develop some proximal thigh mass. That's a good thing, right?
That could be a whole nother
reservations
episode. How runners' bodies need to change across a year, or triathletes. Like, you should not look the same across the whole year. Whether we're talking about strength, whether we're talking about anything, but, you know, that's not what tends to happen. We get worried about, got to race light, you know, got to be tiny.
Yeah. I don't have I'm reading this great book from John Davis about basically training middle and long distance runners. And he's just done a fantastic job of synthesizing a lot of stuff and delivering it in a relatively easy to understand manner. There's some hard science there about energy systems, but you can't dumb that down too much. But, you know, all that matters at the end of the day, if you want to get into numbers, is in your competing, you know, outside of, like, of course, did you have fun, is, you know, where'd you finish? You know, who cares about your weight? There are plenty of people who, I mean, Christian Blumenfeld staring everyone in the face right now. Like, everyone's like, oh, he doesn't look the part. The commentators keep saying that. Well, fucking beat him, you know, and then start telling me, sorry to curse, but, like,
gosh,
I don't have a scale in my house. I don't have a scale in my house, man. It's like, I don't look at this stuff. People, how much do you weigh? I don't know.
Yeah, I don't know. You know? That's a good question.
So,
I don't know. Yeah. People can check out the show notes if they want to look at any of the resources that we mentioned.